Nigeria is among the 30 high TB burden countries due to limited access to TB screening and testing services. But with support from USAID, the National TB Programme, the Stop TB Partnership and aligned stakeholders, Bashir Ahmad, a local radiographer, is able to set up and run systematic rapid screenings in Nigeria's most remote areas. He's on the front line, saving lives, cycling to hard-to-reach communities using the ultra-portable digital X-ray system and computer-aided detection, or AI software.
It's my responsibility to take the examination in terms of positioning the patient, then we'll collect his samples. CAT4TB is really helping because actually it can detect TB at early stage. That's the first one. And secondly, the heat map can show you the patches around the chest. If there is any patches, you'll see it with your eyes. It's my town, my community, my people. So it's a dream. So I want to give back to them by helping them or by doing this work. It's my passion. I want to follow my passion.
Good morning, good afternoon, and perhaps good evening to you all. Welcome to Delft Imaging's first webinar for 2023. We really appreciate and value you all for taking your time to join us. And as usual, we promise to make it worthwhile. Okay, so my name is Baaba Julia Pobee. I will be your host for today. I'm the Senior HR Manager at Delft Imaging. And kindly note a few instructions before we go ahead. Please make sure to turn on the right channel, and also note that this webinar is being simultaneously interpreted in Arabic, French, and Russian. So to listen to any of these languages, click on the interpretation button and select your language.
This webinar is being simultaneously interpreted in Arabic, French, and Russian. To listen in Arabic, French, or Russian, click on the interpretation button and select your language.
هذا الملتقى به ترجمة فورية بالعربية، الفرنسية والروسية. للاستماع للغة العربية أو الفرنسية أو الروسية، أرجى الضغط على الزر أسفل الشاشة لاختيار اللغة. Ce webinaire est traduit simultanément en arabe, français et en russe. Pour écouter l'arabe, le français ou le russe, veuillez cliquer sur le bouton et sélectionner votre langue.
Осуществляется синхронный перевод вебинара на арабский, французский и русский языки. Получить доступ к прослушиванию перевода на арабский, французский и русский языки можно путем нажатия иконки «Перевод» и выбора соответствующего языка.
All right, thank you. And one more thing to note is that there will be a Q&A session at the end. And so it is important to send all your questions to the Q&A instead of the chat box. Okay, so when you send all your questions there, our team can answer your questions accordingly. All right, so the topic for today's webinar is strategizing for impactful TB screening, best practices and insights on planning and deploying X-ray and AI, specifically CAD. And it is my pleasure to introduce to you our speakers for today. Of course, we have Mr. Guido Geerts, CEO and founder of Delft Imaging, Mr. Florent Geerts, Business Unit Director, also at Delft Imaging. We have Dr. Fungai Kavenga, Deputy Director in AIDS and TB Unit Control with the Ministry of Health and Childcare National TB Control Program, all the way from Zimbabwe. And then we have Mr. Christopher Togara. He's also Procurement and Supply Management Officer, Middle East International Organization for Migration, all the way from Jordan. And then we have Dr. Stella Zawedde-Muyanja, research scientist, the Infectious Diseases Institute, College of Health Sciences, Makerere University, also all the way from Uganda. And then finally, we have Mr. Mohammed Harbiye, also Business Unit Director at Delft Imaging. And so before we start, I would like to give the floor to Mr. Guido Geerts to give us a short word of welcome. Guido, you have the floor.
Yes, thank you very much, Baaba, and welcome everybody, and a special welcome to the speakers of today. Being one of the elderly people here in the team, I always have the easy task to do a short introduction of the company and of the webinar of today. My name is Guido Geerts, I'm the CEO, and I just want to explain a little bit about the planning and deployment of X-ray and AI and what we experienced in the past years. So Delft Imaging, we started in the 50s, 60s of the former century and have always been focused on TB screening. So originally actually as a manufacturer of hardware. So for the people who are already in TB screening for a very long time, we were used to produce products like the Odelka. And about 15 years ago, we progressed in software development. We started actually with artificial intelligence. So we invented CAT for TB. And this is a totally different ball game. So hardware, of course, is very important. But the possibilities you have with artificial intelligence and specifically the data we will gather, that's something of which I'm convinced will be a game changer in the future. So it's important to have the security and privacy of the data, but what we can do with collecting this data and analyzing this data and also supporting you, the people in the field with all the data, that's something that we see there are a lot of possibilities in that area. So, and I think important when you're now preparing your request to global funds to focus a lot on which hardware, which software, and as much as possible would be my advice to have everything in one hand. So not that you have finger pointing if there is an issue with the software, that they can say it's something with the hardware or the other way around. For us, it doesn't matter if you only use our hardware and somebody else's software, or our software and somebody else's hardware. But I think it's important to have it in one hand. On installation and training, we often see that with installation, that's very much something where the room should be ready if we're talking about stationary X-ray, and that's not often the case. So we can plan, the orders for hardware and software can be on time, shipments can be on time, but often we see that rooms are not ready and that we have issues in the field on storage, but also you can imagine questions about warranty. We've seen projects where for months we had to store the product because the local rooms were not ready. So that those are quite interesting and important things to keep in mind to plan that as good as possible. And it's also about training, not only the training itself, but just to also to be sure you select the right people. So we can see on the help desk we have all the issues that are in the field, and sometimes we see these peaks on certain sites, and if we investigate that, we see that well, there was a good training, sometimes even several trainings, but the basic skills of the local people were not on the right level. So be sure that you select the right people to be trained. One of the other aspects we could see, we had quite a big project a couple of years ago, and the radiographers were not taken into account. So we're talking about the X-ray. A lot of countries, you don't have enough radiologists or radiographers, and they use biomedical engineers, but that's not always something that the local radiology society is very pleased with, specifically if we talk about large projects. So also be sure that you plan your radiographers locally. I think in general with hardware, software installation and training, focus on proven track records. So I always say it's better to make sure you have good products, maybe a bit more expensive on the front than having a lot of issues in the field. And a proven track record helps a lot to be sure that your project eventually will be successful. So on support, of course, we have our help desk, but it's, I think, very important, not only the help desk, but that you realize that if you request for a project at Global Fund, you know, not only focusing on the supply itself in the first year, most of the projects just become up and running in year 2 or year 3, that the team is really up to speed. So it's good to have some extra warranty or some extra support. We do regular refresher trainings because we also see that well, people leave in your team, and the new people have to have a good training as well. But in this as a whole, it's important to be sure to have support for your project for at least 2 or 3 years. Can I have the next slide? So this is just to show all the projects we have done, a lot of different countries, but the problems are very often similar. So as we mentioned, hardware, software, look for proven track records, installation and support, and on the help desk. It's always good to have a good planning and to focus on having at least 2 or 3 years of financial support for your project. So warranty is an important one. I would like to close this one because the next speaker will go into the impact we want to have as Delft Imaging Systems. Delft is a social impact company. We are B Corp, and my colleague Florent will mention a bit more about our accomplishment last year before we start with the external speakers. Thank you very much.
Okay, thank you very much, Guido. And like you said, you are the best person to give a brief history on Delft Imaging. Thank you very much once again. And like Guido mentioned as well, it is important that we share Delft Imaging's impact with you all so that you know that we are actually impacting the world. And so to do that, let me welcome Mr. Florent Geerts to take us through.
Thank you, Baaba, and good morning, good afternoon, everybody. I will keep my part short because, of course, we're much looking forward to the speakers from Zimbabwe, Uganda, and Jordan. But if you can go to the next slide. What I want to talk about today specifically is the annual impact report of this year, of last year, that we published last month. As Guido correctly mentioned, indeed, we're a social enterprise company, which means that we're a private company, but for us, impact always comes first. And we started making this report. The first edition came out in 2021, and the last edition of 2022 came out last month. And we do this to make sure that we hold ourselves also accountable for the results that we get with the projects that we run, and that we monitor and track this accordingly, and that we're able to share insights and learnings from what we see with our partners and clients globally, and that we share that with everybody around the world. So if you can go to the next slide, please. So this is just at a glance our impact of last year. So we have seen, of course, a major push also following the endorsement from WHO, especially on portable X-ray and CAT. So last year we were able to impact over 3 million people with the CAT-free AI software alone, able to implement projects in 32 countries. And of the Delft Light projects, of all the portable X-ray systems that we deployed in the field, 100% we were able to deploy powered by clean energy. We trained over 500 health professionals through trainings that came with those projects, and over 950 professionals globally gained knowledge of AI and digital tools, which is through webinars such as this and other means as well. And through our help desk, we were able to support technical inquiries with, on average, less than 1 day. So if you can go to the next slide. I just wanted to highlight a little bit of what you'll find in this report. And a number of the things that we put there is projects and case studies we were able to implement last year. So just to give one example here, this is the new tools project, the INTP project, which I'm sure a lot of people are familiar with. Project supported by USAID and the StopTB partnership in 7 different countries around the world, namely Bangladesh, DRC, Kenya, Nigeria, Philippines, Uganda, and Vietnam. We're able to support this project with 55 Delft Light portable X-ray systems and 63 CAT4DB boxes. So I think this is, we put some hyperlinks that are also in the report with more information about these projects. And this is just one of the projects highlighted in the report that we want to share with the audience so that people have an idea of, okay, what does a project like this that entail and how was it implemented? You can go to the next slide, please. Yeah, just one case study. I don't want to go through the slides, but just as an example, this project we implemented in Tajikistan, and throughout the annual impact report, there's a number of these different case studies where we have taken different insights and learnings from our clients and partners globally. Like here, we had the opportunity to have people from Tajikistan speak during one of our webinars last year to talk about their program, the amount of people they screened, cases identified, and such. And there's a number of these case studies and also covering different publications throughout the annual impact report that I think provide quite valuable insights to other partners around the world. Our goal is really to see, are there similar cases perhaps to yours, to your own TB screening program, and what can we learn from them? And we really want to share those insights with all of you. Okay, go to the next slide, please. A lot of the innovation globally, what we do is actually comes from, things that we see in the field where we think we can improve our solutions, but we also do that with a lot of feedback and a lot of input from our clients, and that's very much appreciated. So one of the examples, for example, is here on the right, the Wellness Ankeke, which we implemented together or designed together with the KNCV Foundation in Nigeria. They came up with this idea. We made a design together, and they ended up producing it locally. It's actually a small tricycle fitted with TB lamp and a portable X-ray system or Delft Light that can really reach, very mobile, of course, and can really reach the most vulnerable communities that might otherwise not be reachable. So there's also a number of these different innovations throughout the report that might give some inspiration and interesting ideas for others as well. Lastly, if you can go to my next slide, please. What I wanted to reflect is, of course, where we've been able to implement this together with our team, with our offices also in Indonesia and Ghana and here in the Netherlands. But at the end of the day, the impact that we generate and the impact that's reflected in our annual impact report is we're only able to achieve that because of the efforts from our partners and our clients around the world and those who assist them in their efforts. So we really want to thank all of you for making that possible, for putting in all of that effort on a daily basis. And we hope that our annual impact report provides all of you with some insights. We will share the link later on as well. And now, without further ado, I think we very much want to hear from our different speakers that we've invited that have graciously accepted to speak to us about their program today. Thank you, Baaba.
Thank you too, Florent. Okay, so just a little reminder that this webinar is being simultaneously interpreted in Arabic, French, and Russian. So to listen to any of these languages, please click on the interpretation button and select your language. Okay, so I think we can move straight into our first topic for today, and it's my pleasure to once again invite Dr. Fungai Kavenga, Deputy Director in AIDS and TB Units, Ministry of Health and Childcare, National TB Control Program, Zimbabwe. Dr. Kavenga, please have the floor.
Thank you very much, Julia. Greetings, colleagues. All right, my name is Fungai Kavenga, as introduced. I'll take you through our experiences in targeted screening for active TB in Zimbabwe and our plans for rolling out digital X-ray platforms as well as CANS platforms. Next slide, please. So TB, is we're all aware, is the second leading cause of mortality from a single infectious agent worldwide. TB continues to be a public health problem in Zimbabwe. We're on the global watch list for TB, and we're on the global list of 30 high-burden countries for Geerts TB and TB HIV. And we know that most of our missed cases are amongst hard-to-reach populations and hard-to-reach groups. And this was informed by our TB prevalence survey of 2014. So as a country, we know that there is need for interventions to detect these missed cases to combat the spread of TB as well as accelerates progress towards our national and global targets. Next slide, please. So the country is implementing targeted screening for active TB. We call it Task for TB in short. So basically, this is intensified case finding among high-risk groups using mobile X-ray trucks that are equipped with a laboratory. So this intervention offers free TB screening, HIV testing, diabetes screening. We also offer hypertension screening, as well as TB COVID-19 bidirectional screening. So we reach out to our communities to raise demand for this intervention, and we hold at least one screening activity per province per month. So we go from district to district within each province with this track and targeting the hard-to-reach populations, the high-risk groups. Next slide, please. So our current plan in terms of this intervention is to transition. In the past, this intervention was being implemented through a partner. So now we are transitioning this intervention to subnational level so that provinces can implement this on their own. And I can confirm that we've achieved transitioning from partner, implementing partner to provinces. And this transition was supported by the Global Fund. So this implementing partner, that is the Union Zimbabwe Trust, they have the technical expertise. So we made use of that expertise to train our provincial teams before we handed over X-ray trucks to them. So we conducted training in all 10 provinces for March 2022. Next slide, please. So we have distributed at least one truck per province, and each province now has a highly trained and skilled provincial team that is supported by the district teams to implement this intervention. So in each district, a local team comprising of nurses, community health workers, local leaders, they join in when the trucks visit the areas. So these trucks have an X-ray machine and a laboratory equipped with gene expert machine. So we use electric power to charge the power units. We also have solar backup as well as a backup generator if there's need. Next slide, please. So to date, that is from March 2022 to November 2022, we've managed to reach slightly above 15,000 high-risk communities. About 14,000 chest X-rays have been taken, 252 TB cases diagnosed, and 72 new infections of HIV were picked up from about 3,190 people tested for HIV. Next slide, please. So as a country, I think we've learned some lessons from this decentralization exercise. Firstly, there's need for a pilot to clear any operational issues. Capacity building is key so that the subnational levels on the intervention, and it also ensures that they take good care of the equipment and the assets that come with this intervention. Then we also learned that there's need for an in-country service partner to maintain and repair this equipment. And lastly, the chest X-ray is an important tool. I'm sure we've heard from the previous presenters that the X-ray is pivotal in us ending TB as a global epidemic. It is a highly sensitive tool, and as a country, we've proved that its utility among hard to reach and high risk groups. Next slide, please. So this is just implementation in pictures. I think this was in one of the districts at a farming compound. I think you can see the teams there attending to the communities. Next slide, please. So this is just on your right. I think that's just a workstation where we have a client being offered services. I think this is a registration desk. Then on your left, I think that's the doctor there. On the right, trying to interpret an X-ray for a client. Next slide, please. Then in terms of access to radiology, I think we have a plan as a country. Next slide, please. So I'll just give you a context of our health facilities in the country. We have 65 districts in the country and a total of 1,650 health facilities. 4 of these facilities are central hospitals and 8 are provincial hospitals. So our central hospitals, those are our quaternary institutions. Then we have our tertiary institutions as the provincial hospitals. Then secondary level, those are district hospitals. Next slide. So the target is to have at least one functional digital X-ray machine in each district hospital and one functional machine in each mission hospital. The ideal would be to have a functional machine in each institution, in each health institution. So that would be about 1,646. machines in total. So an assessment that was done into available X-ray machines, I think we have 36 that are available versus the ideal, shows that there's need to have innovative solutions to ensure universal access to radiological services. Next slide, please. So as of May 2021, we had 57 working X-ray machines. 36 of those are digital X-ray machines. So that means we have a gap of 80. We have a minimum gap of 80 X-ray machines that need to be installed with the CAD software. So at the moment, no X-ray machine in the country is CAD software. Next slide, please. So this is just showing the requirements in terms of digital X-ray machines disaggregated by province. So this is informed by the number of facilities and the needs. So as you can see, but it's not uniform across the provinces. Next slide, please. So we have come up with plans to bridge the gap. Next slide, please. Okay, so we need a total of 80 static digital X-ray machines, and these will be distributed by facility. We have a breakdown of which is available on that link, and priority of distribution of these digital X-ray machines will be given to high volume sites as per our TB distribution of our TB burden. Next slide, please. Then in terms of portable X-rays, the plan is each central and provincial hospital should have at least one portable X-ray machine. Then in each district we require at least one portable machine. That is if we manage to address the shortage of static machines. So in the meantime, we procured 14 portable X-ray machines, and we have plans to do a pilot in 3 provinces, 1 rural province and 2 urban provinces, so that we identify any challenges and best approach to use. So beyond the pilot, we will need a minimum of 40 portable X-ray machines, which will be distributed during the scale-up, and these will be distributed to high-risk and hard-to-reach sites for both facility and community-based screening. So these portable X-ray machines will be stationed at high-volume facilities, as well as go down deep into the communities for screening. Next slide. So this is just the proposed distribution of the portable X-ray machine disaggregated by province. Again, like I highlighted, distribution depends on the needs and the burden of disease. So as you can see, we as a country, we have a higher burden in our Midlands and Southern provinces, and they're also earmarked to receive more support in terms of this technology. Next slide, please. So as we are planning to do the pilots, we've done a checklist of things that we need to put in place before we implement the pilot of the portable X-ray machines. First thing is capacity building for the X-ray operators, the managers in the provinces, and technicians. We need a weekly reporting platform so that we'll be able to track the data and make timely decisions. There is need for after-sales technical support so that we don't face any glitches. Then, of course, we plan for an evaluation meeting after 3 months. And this evaluation meeting will inform scale-up of this intervention. Next slide, please. So in terms of the scale up, we brainstormed what we may need to put in place. So obviously, I highlighted we need about 40 machines. There's need of capacity building, and of course, we'll be armed with the evaluation baseline, and of course, the after-sales technical support will also be needed. Next slide. All right, I think I've come to the end of my presentation. So on your screens, the technology we acquired from Delft Imaging, and I can confirm these trucks are on the road and serving our underserved communities. Thank you very much. Back to you, Madam Chair.
Thank you again, Dr. Kavenga. Thank you for reminding us that chest X-ray is an important tool in TB case detection. Very well noted there. And just in case you just joined, just a reminder that this webinar is being simultaneously interpreted in Arabic, French, and Russian. So to listen in any of these languages, please click on the interpretation button and select your language. All right, I think we can move straight and welcome Mr. Christopher Togara to take us through the next presentation.
Good morning, good afternoon. Thanks Julia. Thanks to Delft for organizing this very important webinar. We're very happy as IOM to be part of this webinar. And today my topic is on introducing CAD AI in challenging operating environments. What lessons have we learned from the Middle East response? So the Middle East response is a global fund-supported project. It's a regional public health project being implemented in 6 countries, namely Iraq, Jordan, Lebanon, Palestine, Syria, and Yemen. And as you all very well know, or most of us very well know, that the Global Fund supports 3 diseases: malaria, HIV, and TB. And so my focus today is on the introduction of CAD AI for diagnosing or improving our TB screening. The presentation will touch on the overview of the project, the numbers that we have. I'll take you through the numbers that we have in terms of notification, which is informed why we have gone for CAD AI, the current challenges, and where we are at in terms of introducing this technology. I must point out that we are at the very beginning of introducing this technology to the project, and we are also learning. So at the moment, we do not have data yet, but however, we're in the process of setting up the software and linking up the hardware to the devices that we have so that we can start reading images from this technology. Next slide, please. So quickly, the Middle East response, like I said, is a global fund supported project. We are now in phase 3 of the project, which started in 2022, ending in December 2024. And IOM is the principal recipient of the grant. What do we aim to achieve? We are aiming to ensure essential HIV, tuberculosis, and malaria services, prevention, diagnosis, and treatment are provided to refugees, IDPs, migrants, key affected and hard-to-reach populations. I have already mentioned the number of countries and identified the countries where we are in. And these countries are classified as, by the Global Fund, as challenging operating environment because of the difficulties in terms of access and basic implementation in those countries. Next slide. So again, this is also a quick slide to give you an idea of the countries we operate in. These are the countries in red, and the population sizes of each of the countries. We have over 100 million people in the 6 countries that we are in. And of course, we are targeting refugees, migrants in Jordan, Lebanon, and key populations in these countries. We have a 71 million budget for the 3 diseases, again, for this current phase of the project, 2022 to 2024. Next slide. Yeah, this slide takes you, gives you a snapshot of what we're talking about in terms of TB notification. And of interest here will be that if you look at this closely, there is an overall cumulative increase in notification over the years. And this is in no small part due to the role of the project in increasing notification. And you'll see also quickly asterisks on Jordan and Lebanon. This is because these are only, previously we were recording refugees and migrant numbers only, excluding refugee populations. So this is, of course, has changed. And you will see also in 2019, 2020, the drop in numbers. This is due to COVID. And Syria only there, which I've circled, had positive percentage because the facilities remained open during COVID and there were no restrictions on movement. In Jordan and Lebanon, you also see that 2020-21 there was a drop in migrant numbers. Next slide, because of COVID. Particular interest here, I mean, this is data from the Global TB report. WHO used the slight difference in the numbers on this slide and the previous slide due to the reporting timeframes from the programs as well as for the WHO Global TB report. But again, the numbers show that we still have gaps to cover in terms of reaching to the estimated cases. Next slide. So 4 out of the 6 countries that we have in elimination or pre-elimination phase. And what that means is we need to increase, countries have to increase coverage to achieve elimination. This is these slides that I'm sharing here to give you an idea or to focus us on why we have gone for CAT for TB in this project. Next slide. There are a number of cases attributable to the 5 risk factors for TB. So CAT for TB here, or sorry, CAD AI will be part of a more sensitive diagnostic pathway to early detection of tuberculosis, prioritizing populations more at risk for TB. I think this is self-explanatory, but this helps us zero in on areas where we need to find more cases and therefore deploy resources. So this informs our planning in terms of deployment of diagnostics machines as well as the CAD AI technology. Next slide. So operating in what I've already alluded to as a challenging operating environment, these are some of the challenges we are coming across: political and economic instability. We're also seeing limited stakeholder involvement, zero or to limited domestic funding for health services, limited skilled human resources. I think my colleague also pointed that out. Centralized TB services at government level, insufficient diagnostic facilities, digital X-rays, gene expert as well. But I must also point out that under the current Global Fund projects from the C19 budgets as well as the standard grants, we are bringing in quite a few portable X-ray devices, mobile X-ray vans, as well as digital X-ray machines. So that will also address the gaps that we currently have. We have insufficient drug susceptibility testing. Next slide, please. So, having looked at the current situation we are in as the EMEA, we decided to go for CAD AI. So we then said, because of the resources that we had, we said we're going to implement this as a pilot, and then with informed by the data and figures from the pilot phase, we then expand. So because this was new technology, hitherto not available in the country, and perhaps data not available anywhere in the world, particularly in humanitarian settings, as to how this would work, we had to go into an intensive information gathering exercise, consultations with the donor stakeholders, vendors who are supplying this technology, to gather information on how we could be introduced this. So we needed as much information as we could get. And of particular interest here is that so big was the drive that we initiated this exercise during COVID, when there were restriction movement and face-to-face interactions. And so we had to organize webinars with various suppliers of this technology virtually, because we really wanted to have this going. So after all these consultations had been done, we now could be in a position to define specifications and also identify areas where we needed to set this up. So the pilot phase is being, the pilot is being done in 4 countries at the moment, in Iraq, Jordan, Lebanon, and Syria. And why those countries is because we have digital X-ray devices there. And we said we could set up the technology on the 24 digital X-ray machines that we have, 16 in Iraq, 4 in Jordan, 2 in Lebanon, and 1 in Syria. The one in Syria is a mobile X-ray van. So, and after defining technical specifications, we then had to say, okay, of course, that included what criteria or what would be the type of technology that would work in our region. So we looked at issues like ability to be deployed and operate offline on image databases, option of online if needed, data backup systems, probability score, predefined probability score for preset for TB screening, and image output, defined method of annotation and abnormal X-ray chest X-ray image, including HITMAC or acceptable box. And then we went out to do a request for proposals in fulfillment of our procurement guidelines. Bids analysis followed, and then we started shipping the products to the different countries that we targeted for the pilot. So now where we are at is mostly installation and training. And I must also point out that the winning bid came from Delft. And we're grateful to Delft for the support that they have given to us since we have awarded them this contract to supply the hardware for us to start using this technology in our program. Next slide, please. So the challenges thus far in terms of implementation, and like I said, we just starting. Shipping challenges to Syria due to sanctions, we managed to overcome this. Of course, there are issues with respect to the movement of products into places like Syria because of the embargo that's on the country, but we did manage to ship the hardware into the country. We are seeing also compatibility issues with some digital X-ray systems. And for this, we are again working with different manufacturers of X-ray systems to ensure that the linking up of the X-ray devices and the software and hardware cut for TB is works seamlessly. From stakeholders, we are also hearing that there are concerns regarding privacy and security by stakeholders. So there's also a little bit of discussions to be had on this to ensure that everyone has the understanding of what this is about and how data and patient information will be handled. There is, yes, of course, some reluctance, but this is attributable to maybe education, where we need to raise awareness, further awareness of this technology, the benefits of it, and how it will work in terms of improving our TB screening activities. Again, we're saying we're having challenges in terms of installation and training. In some instances, we feel that perhaps training could have been better delivered on site. The access issues I've highlighted earlier on makes it challenging, say, for example, for technicians to travel to places like Syria or even Iraq in some instances. And we foresee similar issues in terms of accessing places like Yemen when we roll out this technology to Yemen, as we are planning to do. So again, we are in coordination with our focal persons at Delft to have this sorted out. Next slide. Next steps. So we are going to, of course, review and analyze pilot phase data, what we have learned from the pilot phase, where perhaps we can adjust and prove on, and then that data will inform the size of our expansion and how we're going to implement or have CAD AI in all the devices that we are bringing in. Just as some bit of information, we have 7 mobile X-ray vans that are being procured for Syria and Yemen. We already have 2 that have been delivered in Jordan, another 3 in Syria as well. We have a total of 21 portable X-ray machines that are being procured, 4 for Iraq, 14 for Yemen. So that means, and the aim that we have, or our plan, is to ensure that each and every one of these devices is linked to a hardware device for CAD AI. So we are really on an expansion phase, and we think this is an opportunity for us to grow our partnership as well with Delft and ensure that we reap the benefits we intend to in terms of TB screening activities and reach the target that we have on TB elimination. Thank you very much. And again, my thanks to Delft for organizing this important webinar. Thank you.
Thank you to Mr. Togara for such an insightful and very detailed presentation. Thank you very much once again. Okay, we would like to take this very short poll whilst we stretch our necks and sip some water. So kindly click. I'm sure you can see it on your screens. Just select your answer. How many Delft Imaging webinars have you attended, including this one? So please choose your answer and we'll see at the end of the webinar. Okay. So whilst you do that, you can stretch your necks and sip some water or some coffee. And then in about 30 seconds, we begin with our next presentation. Okay, I hope we can all see it on our screen. How many Delft Imaging webinars have you attended, including this very one? Kindly answer and we'll all find out at the end of the webinar. Okay, so just a few more seconds to go. I just want to remind you again that the webinar is being interpreted in 3 other languages, Arabic, French, and Russian. And so you can click on the interpretation button to select your language. I think we have all rested enough and we can move on to another very important presentation for today. And so I would like to welcome Dr. Stella Zawedde-Muyanja to take us through the next presentation. The floor is yours, Dr. Stella.
Thank you, Julia. I hope everyone can hear me. Okay, so we're going to slightly shift gears from implementation to sort of calibration. So sorry, we have the union logo here because this work was presented at the recently concluded union conference. So my presentation is entitled Calibration of the CAD for TB version 7 system for detection of chest X-ray abnormalities associated with TB in Uganda. So as we heard from previous speakers, the CAD for TB comes with many user options, and one of them is sort of a prescribed threshold score, but also with the liberty to titrate it and calibrate it for specific populations. So that's what we set out to do for the Ugandan population. Uganda is a high TB and HIV burden country. About 30% of all our TB cases are HIV co-infected. We also have quite a number of younger people with TB. And so we wanted to test and see how does the threshold score that is recommended, how does it function in our setting? Next slide. Next slide. Next slide, please. Okay, so so we know that the previous slide, sorry. Okay, yeah, so we know that the consideration for the appropriate CAD threshold score depends, one, on the prevalence of TB in your setting and the prevalence of other relevant comorbidities like HIV, diabetes, or even the proportion of patients who have previously had TB. So the number of people coming back with a second or third or fourth episode for TB. It also depends on where CAD will be placed for screening in the screening algorithm. So, so in Uganda, we have 2 places for CAD. We have in the community outreaches where we put our digital X-ray and our CAD machines in big vans and they go through the countryside. We want to maximize detection, so we use it as a first screen. So everybody who comes to a community outreach, regardless of TB symptoms, is given a chest X-ray. So that's the first screen. And then if they have a CAD score of 50 or more, then they go on to gene expert testing. But in our health facilities, we use it a little differently. So in our health facilities, we use it to improve the efficiency of the triage system. And this is what is being proposed because we are now revising our algorithm because we know that cough for more than 2 weeks is not a very sensitive is not a very sensitive symptom screen. And so we are looking at sort of reducing the required duration. And we thought that having a CAD as sort of like a second screen would help, improve the efficiency of that triage system. So we don't have to collect so many samples and test them for TB when people don't really have TB. Next slide. So this work was sponsored by the WHO Stop TB Partnership through the TB Reach funding mechanism. And this was wave 8. And so it had a programmatic aim, which was to increase TB case detection through engagement of private providers, and also an implementation research aim, which was to calibrate an ideal threshold score for the diagnosis of TB using the CAD for TB version 7. Next slide. Yeah, so what did we do? So at health facilities, so we chose two health facilities where all patients attending the HIV clinic were given a WHO symptom screen, and if they had cough of any duration, they were then given both a chest X-ray and a gene expert test. Then we also had a screening in the OPD, where all patients coming into the OPD were given an HIV test, a pregnancy test if they were female, and a WHO symptom screen. If they had cough of any duration, with or without chest pain, evening fevers, night sweats, then they were also given a chest X-ray and a gene expert test. So for HIV patients, if patients were newly diagnosed with HIV, regardless of whether they had symptoms, they also got a chest X-ray. And if patients were returning to HIV care after more than 3 months being lost to follow-up, they also got a chest X-ray and a gene expert test, regardless of whether they had symptoms or not. And then if the gene expert test was positive, the patients were treated for TB. If there was rifampicin resistance, they were referred to the MDR TB treatment unit for second-line therapy. And if they had, if the gene expert test was negative, although they had an abnormal chest X-ray, they were then referred to the physician for further evaluation and management. And if they had a normal chest X-ray and they were MTB negative, then they were sent home. Next slide. So overall, we had over about 6 months of screening, we had 1,344 patients. Of these, 621 were HIV positive and 723 were HIV negative. There were no differences in gender and age and mean BMI between those who were HIV positive or negative. However, there was a difference in age. We find that the HIV positive population was a little older than the HIV negative population. Next slide. Yeah, so about 12% of our patients had previous TB, and a small proportion had concomitant non-communicable diseases like diabetes and hypertension. Tobacco use wasn't very high. It was about 7% in our population. Next slide. Yes, so we calculated the sensitivity and specificity of different HAD for TB sort of threshold scores. And we disaggregated this by HIV positive and HIV negative. So here we see that as a country, we are using a threshold score of 50, which among HIV positive patients, the health facility, not in the community, but at the health facility, had a suboptimal sensitivity. So it had a sensitivity of about 70%, whereas WHO recommends for screening tools sensitivity of about 90%. So in order to get sensitivity close to the WHO recommendation, we would have, for HIV positive patients at the health facility, we would have to decrease our threshold score to about 15%. Next slide. Next slide. Yes. However, okay, so these are the results for, I think we've missed a slide for HIV negatives. Yes. So we found that for HIV negatives, the recommended threshold score did not fare very badly. So we had a sensitivity of 85%. And if we lowered it to about 30, then we'd go beyond the 90% sensitivity required for screening tools for WHO. However, we know that there is sort of like a trade-off between threshold score selection and the number of cartridges you're using, because the lower your threshold score, the more cartridges you need to use. So we found that for the HIV positives, lowering the threshold score to achieve a sensitivity of 90% would increase expert use by about 20%. Whereas for HIV negatives, it would increase the number of expert tests used by about 10%. Next slide. So combining the two populations, HIV negative and positive, in the event that clinicians do not have HIV tests readily available, then we find that the recommended threshold score had a sensitivity of 78%, very close to 80. But if we wanted to increase that to 90%, then we would have to lower the threshold score to about 20. And this would increase our cartridge use by 20%. Next slide. Yes, so what we learned from this study is that we need more data from the Ugandan setting on optimizing the card for TB threshold scores for TB screening in the facility setting, so that we can enable our healthcare workers to detect an optimum number of TB cases while significantly reducing the number of expert tests that are needed. The follow-on benefits to optimizing this card threshold score would be reduced results turnaround time, because then the labs would not be so overwhelmed with testing so many patients with expert, and probably reductions in pretreatment loss to follow-up, because we've seen that in our setting, the longer the turnaround time for a gene expert for a sputum test, the higher the probability that that patient will leave the facility, will not come back for their result, and will ultimately have pretreatment loss to follow up. We also know from previous studies carried out in Uganda that patients who experience pretreatment loss to follow up have much higher mortality than those who are successfully started, linked to TB treatment. So if we could optimize the threshold score, then these could be the sort of like tail end long-term benefits to this. However, we have to balance this against the cost of card, the cost of X-ray machines, and the cost of personnel to operate these X-rays. So what has happened in Uganda since this study is that we've also had quite a big rollout of digital X-rays and CAD. We now have maybe about 20 digital X-rays with CAD in the country, and some of them have been placed in mobile vans and do community outreaches, and we will have to calibrate a different threshold score for that. But about 15 of them have been placed in regional referral hospitals. And so we are collecting more data, more representative data countrywide, to try and see what is the optimal threshold score for TB screening at the health facility in Uganda. So next slide. Yes, so a very big thank you to Delft Technologies, to the Uganda Ministry of Health, which allowed us to do this study at public health facilities, to the Stop TB Partnership, which provided the money for this study, and to the staff and the patients who carried out this work. Thank you very much.
Thank you to Dr. Stella. Thank you. Just a short and a quick reminder, we've seen your questions, and if you can Kindly send your questions to the Q&A section instead of the chat box. My colleagues are on standby to answer all your questions. So please send all your questions to the Q&A instead of the chat box, okay? And then I want to remind you again that the webinar is being interpreted in 3 other languages: Arabic, French, and Russian. And so to listen in any of these languages, please click on the interpretation button and select your language. Okay, so thank you all so much for your presentations so far. On this note, I want to hand over to Mr. Mohammed Harbiye, Business Unit Director at Delft Imaging.
Thank you very much, Baaba. I will be, next slide, please. Thank you. So I will be speaking in relation to the planning as well. And a part of that is also the choice of which X-ray you would choose for your program, whether that is active case finding, passive case finding, or a prevalence survey. So the X-ray systems are categorized in 3 different categories. We have the stationary X-rays, which we have the ECDR, Compass DR, and the containerized clinics, which usually will be placed either inside of a hospital clinic or next to a hospital or clinic. Our mobile solutions, the Mac M1 or the one-stop TB mobile clinic, and ultra portable, the Delft Light and Delft Ultra. Dependable on how portable the system is, so the higher the portability, the less throughput it will have. You can see that on the left image here. So for example, the Delft Ultra can do 50 screenings a day, the Delft Light 200 images per day, and the ECDR's compasses can do 300 plus images in one day. So dependable on what you are searching for, you can choose which X-ray fits well within your program. So as an example, also I would like to highlight that if you are curious to see how these X-rays have been used, you can review that in our impact report, as my colleague Florent already described. And as an example, also I would like to highlight that for Dr. Fungai Kavenga, that in Zimbabwe we are going to supply 2 different X-ray machines because they have different functions, 31 Compass DRs and 14 Macs, and based on that we can assist in the gap that is now in the country. Of course, only supplying an X-ray is not enough. You need to have an integrated and holistic approach in that. So that's why the slide here is showing the integration with CAT AI software, whether it's the online solution or the offline solution or both, combined of course with the CAT4TB platform, including statistics to further optimize, as Dr. Stella mentioned, further optimize your program. And that all by the supply of service and support to be able and make sure that the team is trained, also follow-up training by e-learning, we assist in project management and also service and maintenance. Our systems are available at the GDF catalog, PFSCM Wambo, and the UN Web by Plus. Next slide, please. So indeed, it is for us, we always try to look at it from an integration and a holistic approach. We don't like to look at X-ray only as X-ray. That doesn't make sense to us. It's a value proposition that we provide. Digital X-ray without CAT4TB, it's not what we offer. We'd like to have it as a full product. So our TB impact is our focus is to accelerate TB case notification by reduce the cost of case notified, and by reaching key populations in resource constrained settings. That all by having a sustainable program. So we have an integrated solution for total ownership, the ease of total cost of product ownership, by maximizing technical life. And we provide, of course, also solar-powered solutions and learning. And we provide training by lowering the learning curve. Next slide, please. So how do we support the TB programs? We support them by providing optimized digital X-rays and CAT. We focus on multi-disease platforms, so we provide CAT for TB as a TB solution, but we also look at beyond. How can we optimize with multiple diseases? And that all is integrated in a TB data management system, the CAT for TB platform. Next slide. Focus should always be to have a well-trained team, and we focus on providing the right maintenance and service support. We have a diverse technical and management team that will assist in that, and that all by having a transparent solution, so to minimize the hidden costs, which usually are more than the purchase price itself, and that's all in favor of the total cost of ownership for the program. Thank you. I think that's it for my slides. Yes.
Yes, perfect. Thank you, Mohammed. Then I'll take it from there for the Q&A. First, we would like to thank all of our different speakers for speaking during our webinar again today. I think it's very valuable, a lot of different insights and learnings. I think the presentation from Dr. Kavenga was also very much appreciated, providing such an overview on what Zimbabwe is doing as a country, but also a lot of detail on how that approach actually entails. Same for Mr. Christopher, what IOM is doing in the region and how it's approaching it, not just as separate countries. Of course, there are differences and different challenges, especially when it comes to logistics in certain cases, as he explained, but also like what are some of the cross-cutting challenges that you see across the region and what are considerations to solve it. And also our appreciation to Dr. Stella's very insightful presentation about CAT for TB and how to set the right threshold for your country. I wanted to say also thanks to the audience for joining us and for all of the questions that you've asked so far. A number of them have been answered, I think, already in the Q&A chat, but I wanted to pick a couple of them. I don't think we'll have time for all of them, but rest assured, we always send the Q&A sheet after the webinar as well. So if your question is not answered live during the Q&A, we'll make sure to send you the answer. I wanted to start actually with a question from Ellen Mitchell to Dr. Stella. I think it's a very good question. There's a lot of talk, of course, about what's the right threshold for CAT solutions. CAT3 provides a score between 0 and 100, and how do you set the right threshold for this? And Ellen Mitchell mentioned there's a lot of emphasis on setting the right threshold, and the recommended method is quite expensive and quite time demanding. It's essentially a full diagnostic accuracy study. What alternative calibration methods are there for countries that are under pressure to implement digital X-ray with CAT quickly and sustainably? Could pooling for the lower CAT scores be an option instead of universal testing? Dr. Stella, could you perhaps shed some light on that for us from your perspective?
Sorry, all right. Thank you for this question. Okay, I'm sort of rereading it. For the lower CAT score instead of universal testing. Okay, so I agree. I do agree. The sample sizes needed are very, very high, and even in our study, we didn't quite reach the sample size that is needed. However, there are alternative, I think, calibration methods where you can use a case control study, where I think the sample sizes needed are a bit smaller, like 348 or 350, round about there, cases and 300 controls. So I remember we did get some training from the WHO on that. However, yes, sputum pooling for lower CAT scores would be is an option. The only problem is having then to go back and, or unless you have a pooling system that can detect which is the positive patient without having to go back and test all the positive samples. But yes, a pooling system would be would be an alternative. And then you asked a question, do you think you can operationalize different threshold scores by HIV status? So this is an interesting question that you've asked, because we do have different symptomatic screens by HIV status, which we've been able to operationalize really well. I don't know why there is a fear from everyone that we suddenly can't operationalize different threshold scores by HIV status. Yet for the last 10 years, we've done very well having a different symptom screen for HIV negatives and a different symptom screen, sort of like threshold for HIV positives. So for HIV positives, we say, if you have cough of any duration, then, give us a sputum sample. It doesn't matter whether you have all these other symptoms. For HIV negatives, we say you have to have a cough of more than 2 weeks, or if it's less than 2 weeks, you have to have one of the other symptoms. So, and it's worked really well, at least in Uganda, it's worked really well since 2011. So I'm sure we can, just like we did operationalize a different symptom screen, we can operationalize a different threshold score. So yes, I think, to wrap this up, yes, I think it's difficult to set a threshold score, but I think it's something we need to do. And I think it's something that we can do alongside implementation, so that we don't have to stop completely do a full diagnostic study, wait 2 years before we can implement CAD. I think we can learn as we go. We can start implementation alongside, small nested studies, and then we can titrate our cutoff points as we go along, as more data becomes available.
Thank you, Dr. Stella, for that answer. I think that provides a lot of good insights. I also wanted to emphasize to everybody, and I know that you've actually looked into this as well. It's also good to realize that, of course, as new CAD versions come out and as new performance increases again, it's good to reevaluate the threshold that you've been using before. I don't know if you could briefly say something about this, Dr. Stella. I know that you looked at CAD for TB6 and CAD for TB7 as well. I know your presentation today was about CAD for TB7 specifically. Was wondering if you could say something briefly about that as well.
Yes, I think there was work done not from a number of different countries that showed that the threshold score for CAD for TB version 7 was more sensitive. So when we had CAD for TB version 6, we were using a threshold score of 60. But then we found that for CAD for TB version 7, that was too high, and then we needed to go down to 50. So once we transitioned to CAD for TB version 7, we then lowered our threshold score to 50. So as different versions come out, we have to, keep iteratively calibrating these threshold scores, because higher versions might need lower threshold scores.
Exactly. Yeah. Thank you, Dr. Stella. I think indeed it's good to reevaluate that with newer versions as well. And I like the practical approach that we don't need to halt the program of the country in order to set the right threshold. That it's something that can perhaps work parallel as well. So thank you for answering that in detail, Dr. Stella. I wanted to highlight a question that was answered to Dr. Kavenga from whether there are any areas that could not be reached with the trucks and how this was mitigated. I think Dr. Kavenga already answered it, but I wanted to repeat his answer. So due to the poor road network, there are certain areas that are unreachable by trucks, and the program in Zimbabwe intends to use ultramobile X-ray units to screen in these areas. I think this is a very good point also, and I think as my colleague Mr. Mohammed already showed, that there are different solutions for different settings and different challenges. So indeed, a truck has a stationary X-ray system in it, can carry a lot of power. But of course, when you run into challenges such as a poor road network, the truck can't go everywhere. So KNCV Foundation Nigeria solved this a little bit, or made it an alternative approach with their wellness on Keke tricycle, as we showed before. And of course, portable X-ray have a role to play here as well. They carry a little bit less power than a mobile clinic, but can still do, in the case of the Delft Light, for example, 200 exposures per day. And it can actually go to those sites where perhaps roadblocks would hinder operation. So it's good to realize that there's not one X-ray system or one mobile clinic that works and is ideal for every setting. It should indeed be a combination of different ones. I wanted to ask a question. I see there was a question asked from Timothy about whether the image analysis occurs on site or if the data must be sent elsewhere for analysis. And if so, what are the bandwidth and connectivity requirements? I wanted to ask this question, Mr. Christopher. You talked about the implementation of the Get4TB boxes, using that offline. Of course, I can imagine there might be certain challenges in relation to the connectivity in some of the countries that IOM operates in. Could you perhaps talk a little bit about this? So the question was whether the image analysis occurs on site or if the data has to be sent elsewhere for analysis.
If I had the question correct, I think the images are connected to the images are sent to the cloud, and then the reading is done by users on the ground in terms of interpretation and so forth. I hope I've heard the question well. In terms of what exactly is has been asked. Sorry for that, Florent. I didn't quite pick the question.
No, I think you answered it indeed correctly. So the question was indeed about, okay, the processing of the AI software. Can this be done offline, or does it need to be sent up to the cloud? And how does that actually work in practice?
Okay.
Yeah, and I think this is indeed an important point. So, of course, artificial intelligence software, it can work in the cloud, but especially in the context of TB screening, and especially in the context of, going to more remote areas with mobile clinics or with portable X-ray, you will have a lot of cases, of course, where there might not be any connectivity at all, or the connectivity might not be quick enough to get, the speed of the results that you need to have a smooth operation. So the internet connectivity in the context of TB screening, I think, is something that you never want to be fully dependent on. And that's something where we have the Get4TB boxes, which is also in use in, also in Uganda, also being delivered to Zimbabwe, and also used by IOM, which is actually enables the Get4TB software to work fully offline. So you are never dependent on internet connectivity. If possible, it can be connected still to the cloud. So what is possible is that if you have multiple sites, for example, you connect them in the cloud so that those sites upload to one central location, which can of course be helpful because it gives the program and management insights to that from a more central point of view, rather than only decentralized at individual locations. But I think with those boxes, it does allow everything to work fully offline. I think that's of course something that we need in the program in practice. So I see that we're come to the end of the webinar. We will send, I'm sorry we didn't get to answer all of the questions. I see some new comments also just came in. Again, we will make sure that we will send the full Q&A sheet to you. I think there's a number of interesting insights. I think one of the questions here was about what HR is needed for an activity in relation to the presentation of Zimbabwe, and Dr. Kavenga answered very detailed on the personnel that they have to operate their program. So I think a lot of insights there. After the webinar, we'll share with everybody the recording, we'll share the presentation, we'll share the annual impact report that we spoke about earlier, and as well as a detailed Q&A sheet. For now, I would like to once again thank everybody for attending the webinar today. Those of you attending from around the world, and in particular to to all of our speakers who were here today and who shared their insights and their learning with us. So I want to thank everybody here. With this, we will end the webinar, and we will look forward to seeing you again in our next quarterly webinar. Thank you, everybody. Have a good day.